I'm going to try today to give you guys some information related to i-Dixel, related to your units, about patient positioning, scanning, how to maximize your image quality, give you guys some pointers on how to better plan your cases. And then from there, we can actually have a little bit of a debate in the end. As I was talking to Mr. Slimin about, i-Dixel, he was mentioning to me that our colleagues there in the Middle East were having some questions related to how to better use i-Dixel, better use the CBCT units that you own. And I want to let you know that you can rest assured knowing that you have the top hardware in the world today when it comes to oral maxillofacial radiology. Morita is well known worldwide for two things: resolution and reliability. As the former director of the largest radiology department here in North America, somebody that has used pretty much every single piece of hardware out there, I can honestly tell you that every time that I have a chance to work with multiple units, I always navigate towards Morita. It is, in my opinion, the best system out there to help you image for your patients regarding surgeries, regarding endo, and also implants. So I'll show you today why my experience has been so positive with Morita and what are the differentials that you should look for. Also, I'll try to help you as much as I can to calibrate your image quality and help you with patient positioning and little tricks that can actually help you increase your resolution in your workflow even further. It's also important to stress that Morita is the company that started a revolution of Conebeam-CT imaging. Dr. Yoshinori Arai is the father of Conebeam-CT imaging the way we know it, at least high resolution Conebeam-CT imaging the way we know it. And Morita is now celebrating over 20 years of CBCT imaging in dentistry. So again, just a shout out to my peeps there in Japan. You guys been doing extremely good work for the past 20 years, and I look forward to see what's ahead. Now, it's very safe to say that folks that are here today are pretty much using one of those three units, meaning that the last two, the VeraView Epox R100 and all the units related to X800 are probably the most popular among the Middle East market. And if you are using those two, the R100, X800, this is where we're going to focus today. Okay, and it's important to also to stress that there is a learning curve related to software, related to hardware, and also related to engineering. We are all learning here. I know Mr. Slimin now for almost 20 years that we've been, friends and colleagues, and we've been discussing things about how to improve the units and how to improve image quality. And I think it's awesome when groups like this can share experiences, share pains, and it's important also for the folks in Japan to hear a little bit on how to maximize image quality. What are some of the pains that you guys are suffering there as clinicians, so the engineers can try to find solutions for some of the problems that we are talking about. The goal today, again, like I said, is to help you increase your clinical knowledge regarding 3D imaging, but most importantly, regarding i-Dixel and regarding the piece of hardware that you have. There are a lot of little things related to i-Dixel, related to even the hardware component with patient parameters, imaging parameters that we don't sometimes pay too much attention to, and that can be, the switch of that can determine, a good image versus a great image. So before we start, it's important that you understand that imaging, any type of imaging, we have to navigate through 4 pillars, okay? Those 4 pillars are interconnected, and you cannot change this sequence. Everything starts with acquisition. Acquisition is the #1 pillar for the imaging workflow. After acquisition, we have data correction. After data correction, we have data navigation. And only after data navigation, we can get to data interpretation. So in order for you to maximize your data interpretation, you have to maximize your data acquisition, your data correction, your data navigation, and to get to data interpretation. If your data acquisition is not ideal, your data interpretation will suffer. If your data correction is not ideal, your data interpretation will suffer. And if your data navigation is not ideal, again, your data interpretation suffers. And everything starts with the first pillar, right? The acquisition. So one of the things that I do every time that I'm looking at new systems or new Conebeam-CT scanners, I always want to know, how is the acquisition workflow and what is it different about it? Also, I want to know what are some of the data, what are the data correction tools that we have? Then the data navigation tools, how do I slice and dice the volume? And most importantly, also, what is the correct sequence for that? Then we can talk about imaging patterns related to data interpretation. Now, I think the Morita shines when it comes to the data acquisition, data correction, and data navigation component. There are tons of excellent tools there that allows us to really differentiate ourselves as imaging centers or clinicians when we use this product. And the final product is going to be a high resolution scan with minimum artifacts and minimum scatter. So questions that I get all the time is, Bruno, why is your database so good? Why are all your scans, perfect? It's because I pay a lot of attention on pillar number one, acquisition. Acquisition to me is just more than just pushing the button. I want the patients to be perfectly positioned. I want the parameters of the unit to be perfectly adjust for what type of imaging I'm doing. I want to make sure that my scout imaging is placed correctly on the panel scout, and also I can stabilize the patient to the best of my ability. Sometimes, being too friendly with the patient, being not adjusting, for example, the temporal guides, stabilizers, I'm sorry, the temporal stabilizers hard enough. It's enough for the patient to just move a little bit and then make your image tank. So I'm going to share with you my secrets. How do I do it? Why do I get images that look like this all the time? And then hopefully we can share some ideas here throughout the next few hours. So the number one thing that your unit has, the Morita unit, is that it's very user-friendly. Okay, and when I say user-friendly, I'm talking about the fact that when you look at brochures from different manufacturers, and you look, what they all have in common. The interesting thing here is what they all have in common is the fact that the patient on the brochure is always a supermodel with the longest neck a human being can have. So those patients are very easy to position, very easy to stabilize, right? We're looking at, patients with beautiful smiles, but in reality, it's more than just beautiful smiles. Sometimes we have patients with no smiles, and we have to, somehow adjust the machine to better position patients like this. So the idea here is, I want you always to remember this saying: you never adapt the patient to the unit. You adapt the unit to the patient. So the Morita scanners, they will come with different types of chin rest, different types of bite blocks. And it's important that you know when to use them and how to use them. So as we progress with our scanning, the patients are going to be better stabilized. We're going to be able to better aim at the region of interest, and therefore we'll be able to achieve the best image quality as possible. So if you are an R100 user, or if you are an X800 user, you will know that you have those two types of chin rests, one with the bite stick and one with the chin cup. Every time that you have an edentulous patient for the anterior region, meaning if the patient cannot bite on that bite stick, please use the disposable bite block that comes with your unit, okay? Because that is the best way to make sure that you are lining up the maxilla and the mandible to place them together in the focal trough of the unit, and to also to better stabilize the patient from movement. If you try to put cotton rolls here, so on, now what you try to do is you're trying to adjust the patient to the machine. Don't do that. those are some of the reasons why sometimes you don't get great images when you're trying to do that. So make sure that you always adjust it. Now, we have three types of patients that will come to your practice. Patients where their jawline is above their shoulders, and patients where their jawline is at the level of your shoulders or below your shoulders. If that is the case, it's not uncommon for the C-arm, regardless of the unit that you have, to hit the patient on the shoulders like this. So there are ways for you to bypass this problem and ways for you to also bypass the problem of height when it comes to patients. And it's important to remember, particularly if you have an R100 X700, right? If you have this particular unit that has the mirror, that your chin rest has three different positions. Position 1, position 2, position 3. Those three different positions here, we'll discuss it a little bit more in length in a second. They will determine if you actually have the C-arm hitting the patient's shoulders or not. Also, if you have the X800, you can control the height of the chin of the C-arm independently than the chin cup. So the X800, it's a little bit different because when you position your patient, you can control now the horizontal position for your panoramic scouting differently than what you had to do with the X700. So you can see here a couple of things that I do. I always like to position my patients in such a way that I put the tragus right parallel to the infraorbital foramen. Always trying to find where the canine line is. Typically, what we're trying to do here is actually find the position of the apices of the central incisors, making sure the patient is well positioned to acquire the scan. Secondly, if the patient has teeth, I can always do the same thing here, right? Instead of adjusting the bite block, I can always have the patient bite the bite stick. One problem that happens all the time is that patients try to bite and then the chin cup prevents the patient from biting. See, this is a very common mistake. So do me a favor, ask your red tack to always show the patient the bite stick. So you're going to say, hey, listen, here's the bite stick. There is a groove on the bottom, a groove on the top. In a second, I'm going to ask you to bite with your front teeth within those grooves, and always make sure to raise the bite block, right? So the patient can actually come in here and bite the bite block without having the chin cup blocking the chin. So it's a much better experience for the patient. I know those are simple things, but always make sure that the patient is biting the bite block. One of those things that I just did here, I always place my finger in front of the forehead of the patient like this, and I ask the patient to try to touch my finger with their forehead. So basically what you're really trying to do is tell the patient to bring their chin to their chest in order to stretch the neck as much as you can possibly can. And this way you avoid what's called a slump position. So see how the patient went forward, and this way I can stretch the neck and really tight this as hard as you can so the patient does not bite. Then you go back again and you stabilize the Frankfurt plane, mid-sagittal line, and the canine line. The canine line is going to be the last line that you're going to adjust. So remember, every time that you put a patient in there, you start with mid-sagittal line, then Frankfurt plane, then the canine line. Always in that sequence. If you start with the canine line and then you go do the other ones, your canine line is going to be off. The canine line is always the last thing we adjust. So from here now I can go take my panel scout, or my Conebeam-CT scan. One thing that most people don't use, it's actually the T-bar. So your units, the X800, the R100, and also the X800 will come with the T-bar. The T-bar is used for TMJ scans. So basically, every time that you have a patient that needs TMJ imaging, you will use the T-bar for that. And what the T-bar does is allows the patient to rest the nose right here on the tip of the T-bar. So you'll see here in a second, I can select what I'm doing, the type of programs that I'm doing, if I'm doing panels or if I'm doing CT. And the reason why I can do I can use the T-bar is that on this position, I can image the patient with the patient opening or closing his or her mouth. So as the patient gets into the unit, if the patient, if need be, I can actually have the patient open his or her mouth and take the scan with the patient with the mouth open. So this way I can see the translation of the condylar heads. So that's what this little disposable, this little T-bar does. Another option for you to use the T-bar in your clinic, if you see trauma patients, particularly somebody that has fell on their chin and there's lacerations now, or the patient has pain by placing the chin on the chin cup or on the chin rest, make sure to use the T-bar. This is also a good substitution for any time the patient cannot put the chin down because of trauma or because of lacerations, of soft tissue lacerations on the chin. Okay, so I would do that. Now, if you have an X700, right, the R100 unit, there are a couple of things you should know about the chin rest position. Every time that you guys are going to take a panoramic image for cone beams, if the area of interest is the mandible, okay, for example, if you're going to do a 4x4 scan on number 36, please place the chin rest on position 1, meaning that all you're going to do is drop the chin rest there, and you'll be able to now take a panoramic image here on position 1. So the reason why you want to place the chin rest on position 1 is to allow you to acquire a smaller field of view, or even a medium field of view of the mandible without the maxilla interfering. But if you want to place, if you want to take a scan of the maxilla on position 1, the vast majority of times, what's going to happen is this. Instead of, oops, let's go one more. What's going to happen is as you move this guy up, this is going to turn red. So if you have problems with the box turning red for the maxilla, that is because your chin rest is too high, and therefore you really can't image this properly. So every time that you do a mandibular scan, I want you guys to use position 1. If you guys are going for a maxillary scan, I want you to go for position 2. So how do I get to position 2? Instead of dropping this straight down, turn the bite block to the right. Okay, turn the bite block to the right, then drop it into this little hole here, and you can see that you're gonna the chin rest is gonna drop about ½ an inch down. And that is the clearance that a lot of times you need to clear the shoulders on larger patients. But most importantly, that's the clearance that allows you to go from here to the maxilla and not have the maxilla turn red, right? Not have the box turn red. Another important component here too is that even though this patient, they made a mistake, they acquired a panoramic image with removable dentures. The metal from that removable dentures is not interfering with the quality of the Conebeam-CT scan. So the idea here is, if you can avoid imaging the crowns of the lower teeth when you're doing upper teeth, please do so. Okay, so this is one of those times that you have to keep thinking about, okay, what is best for me, to include metal from the bottom or to avoid metal from the bottom? It's always important that you try to avoid metal anytime that you're placing those smaller fields of view around. So in this way, as you can see here, we were able to capture that canine perfectly without any interference from the image quality from the mandible. And unfortunately, this patient, as you can see here, there is an area of that is ill-defined and perforating bone, no expansion, soft tissue swelling. This was actually a malignant tumor that was growing behind that canine. It was a case of a minor salivary gland tumor growing in the palate. And then you also have position 3. Position 3 is when you drop the chin cup all the way down, turn it to the left, okay? Turn it to the left, and then this will drop all the way down. You will pretty much cut a little bit of the mandible, but the maxilla will be there. So anytime that you guys have patients with problems with the sinuses, or even challenging patients, patients that have large hunchbacks, or somebody that perhaps looks like her, neck issues here, back issues. You can actually use position 3. Ideally speaking, this is actually the case of a girl similar to that. And we are actually interested in see what the canine was doing. But you can see here that by putting on position 3, I can avoid the C-arm hitting her shoulders, and I have a pretty decent image of the maxilla on that particular case. So if I needed to see anything related to the sinus, scan any area of the sinus, that's what I would use. Here, to show that I can take a scan of that canine and be okay. Now, another component too, every time that you're moving the box around, please think about what's going to be inside the box. So for example, you can see here that adjacent to that area, there's dental implant. One thing that I will not do, it's actually include the dental implant here, because I know that if I were to move this box a little bit more distal and include the dental implant, that dental implant would create artifacts on this particular scan. So the idea is you not only want to move the box up and down and avoid the mandibular crowns, but you can also move the box side to side and avoid areas that can actually create artifacts within the area of interest. So just be mindful of that. Another important thing for you to think about whenever you're doing your panos, particularly if you have an X800, it's going to be your level. So I don't know if you guys are using levels or different levels for your panos. I like to keep my panoramic images with the X800s with level 6 and level 5. Those are the best ones. I think by default, the unit count, it's about 2. So if you are working with, an imaging center and you want to have a better image quality, please make sure your level is a 6. If you are using an X800, X700, this previous unit here, please make sure that on your unit, your level is a 4. That's the maximum we'll go here. So there are 2 different resolutions, right? You have the high-speed resolution and the HD resolution. The differences between the high-speed and the high definition is always the acquisition time. So here on high speed, the panoramic is going to be 7.4 seconds. On the high definition, the panoramic is going to be 15 seconds. If you're just using the panoramic image for scouting the area of interest, then you should use high speed. If you're using the panoramic image for diagnosis, meaning that's the primary reason why you are imaging the patient, you should be using the high definition one. Basically, on the high definition panoramic image, you're going to acquire double the amount of base images than the high speed one. So you're going to have a much higher resolution panel. But the trade-off is that the reconstruction time of that panoramic image is going to be higher. It's going to take longer. So that's why you don't want to use the high definition for scout imaging, although you could, because in reality, it's going to take much longer for the image to actually pop up and allow you now to aim at the area of interest there. So just be mindful of the acquisition time here. High speed, 7 seconds, high definition, 14 seconds, 15 seconds. What is different about the C-arm of the X800 is that I don't have to change positions for the chin cup. The chin cup only has one position. So differently than the 700, right, where I can actually turn to the right for position 2 and turn to the left for position 3. On the X800, the C-arm moves itself up. So here is what I mean by that. If you ever encounter patients doing your panoramic acquisitions where the patient has a hunchback or neck issues, and now you see the C-arm touching their shoulders, please make sure to change your horizontal position. In my clinic, my default horizontal position is 5. This is what I use for everybody. It's 5. But you can go a little bit up to 10 if you want to, and you can see here that now it's not touching his shoulders anymore. But you can go, see, look at that. It just moved a little bit up. Perhaps you would crop a little bit of the inferior border of the mandible, but in this case, it's not really that important because, it's between touching his shoulders or no image at all. I'm sorry, it's about not touching his shoulders or no imaging at all. So here, this is the type of clearance that you can get with the X800 without moving the patient away, without having to change the bite stick. All right, so again, my default setting here is 5 for horizontal position. That. So click here, horizontal position 5, that's my default. So you can go horizontal position 5. Levels, you can adjust on your unit, see what works best for us. The vast majority of the X800s that I work with, I actually work with 3 of them. They actually give different images on different levels, but it's going to be at least 4. This actually, when I was imaging this patient, this was a very small patient. That's why it's on 4, but my average it's 5. Now, one thing that I want to talk about the Morita that is very different that you won't see on other systems are those other programs that they have, particularly this one called the SL. The SL program is called the shadowless program, and a lot of folks don't know when to use this. So let me explain to you, when do we use the shadowless program on your unit? So one of the problems with panoramic imaging is the fact that we have ghost images associated with metal, sometimes earrings, things that are on the buccal aspect of the layer, and then on the posterior side of the mouth, and then therefore they create this ghost artifact, ghost image on the opposite side. So it always happens on the opposite side. So when would you use a shadowless module? Every time that you have ghost images coming, for example, from the Raymond. So if you have a patient that had orthognathic surgery, there's tons of hardware here, and then you are now seeing ghost images on the opposite side, you can use the shadowless module. And as you can see here, this is actually the same patient acquired with the shadowless module. There's no ghost images on the opposite side. Absolutely no ghost images on the opposite side. So here we go, ghost images, no ghost images. That's what the shadowless module is for. And it's a fantastic tool that can help you differentiate your panoramic images from your competitors, just because there will be no ghost images associated with that. Another thing that's important about panoramic imaging from Morita is the fact that it has this direct acquisition module. The direct acquisition module has to do with the fact that the KV and MA is being corrected in real time when you take a panoramic image with Morita, and therefore you have a very homogeneous density on your panels. So you're going to have, you don't have burnout areas with your panoramic image. So the idea is, as the machine rotates around the patient's head, KV and MA is being corrected real time. So it's not uncommon to see this type of problem on competitor systems where, there is a lot of burnout, or sometimes the image gets overexposed. Where on Morita, everything, if you've done the panoramic correctly, everything gets homogeneous from a density perspective. So therefore, when you are taking a scan and you actually compare side by side, this is preferable. And you can also use this to understand where to scan the patient, right? So if you are now using the panoramic image to aim at the area of interest, right, on where to scan the patient, it makes a very fast workflow for particularly your smaller fields of view. There are different fields of view with different capabilities on where to scan the patient. So you can go all the way from larger fields of view like this with the X800 to smaller fields of view. Another option that you can have if you don't want to take panoramics on your patients is to use what's called the 2D scouting. So 2D scouting is available in all Morita units. The X800, the X700, and also the Aquitomo. And what is that? It's when you take a lateral shot and a frontal shot of the anatomy of the patient, and you use those areas to aim at the area of interest. So I can move this box now anterior to posterior here in the maxilla. So in this case, I'm doing the center incisors. And here with the frontal view, I can move this to the right, to the left, or to, to the whatever tooth I want to center. So it's a different way for you to think about on where to take the scan, but every single unit from Morita allows you to take scans using 2D Scout with 2D-dimensional imaging instead of the panoramic. The panoramic imaging, in my view, is preferred because allows us to be very precise at the area of interest, right? So you can see here, high resolution quality panel, and say, this is the area that I want. It's easier for your assistants to know where to aim. And sometimes you can use the panoramic imaging as a screen tool, particularly when the patient has multiple problems. So it helps you determine what is the best field of view for that patient. But the idea here is, if the panoramic image is correctly acquired, the unit is going to make sure that whatever the region of interest is always centered within the center of the field of view. And this is the area that you have the highest resolution within the scan, right? So you can see here a patient that we have this high density finding. It just so happens to be periapical segmental osseous dysplasia, right? This is a stage 3 periapical segmental osseous dysplasia. This patient was also having problems from a root canal perspective. There was a lingual canal that was never filled. And this is actually a problem because every time that you have infection associated with a fibrous osseous lesion, it can lead to osteomyelitis, because the tissue associated with fibrous osseous lesion, it's not as vascular, and therefore it cannot fight infection. So be careful every time that you have situations like this. And again, correct acquired panoramic images will allow us now to aim precisely in any area we want within the jaws, and make sure that whenever you aim at this area, we will include exactly the area that we want, and that will be centered within the scan. And that is the most important thing we can ask for, right? Is for those areas to be centered within the scan. Remember, everything that's in the center of the scan, that's when you're going to have the highest resolution within the scanner. Everything that's on the edges of the scan, they don't have the same resolution of whatever it's on the center part. So every time that you can, try to place the center, try to put the region of interest right in the middle, right in the center of the scan. For those who use the R100 or also the X800, it's important to remember that you also have the ability to crop panoramic images. If you want to do the panoramic bite wings, and that would be back here one very fast, and that would be this module here, where you can go to normal, to shadow last, and then you have the orthogonal projection, which is the OT. So the OT you would use to do the bite wings, panoramic bite wings. That's when you do the OT. And then if you go back here to your panels, you just unselect the condylar heads and the central incisors, and you select the OT. This will be equivalent to what's called a panoramic a bite wing with your Morita X800. So if you actually use the cropped images for Scout, they will also work. So here's a good example of a panoramic, a cropped panoramic image that we use as a Scout, and that actually works really well too. So do not fear not using the full panel if you just don't need it. Another component too is that if you wanted to see this canine here, although it's not on the image, I could actually move this line forward and scan the canine even though I don't see it, right? So the regions adjacent to the cropped panoramic images can also be used, can also be imaged by using the box to aim at the area of interest here. You can see that you got exactly what we wanted. And the challenge that I see in lots of imaging centers and lots of offices, they're using Morita and they're using the panoramic scout. It's this situation here where 50% of the scan, it's composed of information that can create scatter. So think about this for a second. Every time that you guys see this box, you're talking about 2 centimeters to the right, 2 centimeters to the left, 2 centimeters to the top, and 2 centimeters down, because the volume is 4 by 4. If we were to evaluate this, just for a simple math evaluation, 2 centimeters or half, 50% of the scan is just crowns that can truly interfere with image quality. So the idea here is, as much as you can possibly avoid taking those types of scans. I would prefer for you to, in this situation, do something more like this, right? To go in here and acquire just the maxillary crowns and avoid the mandibular crowns. The problem is when we do this, a lot of times this line here will turn red. This doesn't happen with the X800, but does happen with the R100. So just be careful. Place that on position 2 to avoid that turning red. And the challenge is sometimes, and this patient has a little bit of motion and a lot of artifacts related to this. But why? Think about it. 50% of the scan is just garbage. It's just stuff that's creating lots and lots of artifacts. I can have the same situation, okay, same situation, same tooth. And then from here, instead of acquiring the image with all the crowns, I can put it on position 3 or position 2 on my X800 and I'm sorry, X700, R100, and then I can image the crowns now, or even crop the crowns all together and get a much cleaner image, okay? Because those crowns are not interfering with my image quality. So remember this, every time that you have a chance, don't scan areas, okay? Don't scan areas with lots of crowns like this. Try to avoid as much as you can anything that can create artifacts to allow for better image quality of your scans. Now, when you use this, I'll show you a case now. You will have superb resolution, absolutely superb resolution. Okay, so here's a good example of a case where I have, we're going to go over this case in a little bit. This is a fracture case, okay? And I'm going to show you in a bit how to actually look for this fracture, but I just want to show you how right now there's nothing here that is interfering with the image quality of the area of interest that happens to be the premolar. The premolar, it's centered within the scan, exactly where I wanted it to be. And now we're going to go back here in a second. I'm going to show you later on when we talk about navigation, how to actually look for fractures and things like that. This is what came out of the unit. I haven't touched anything. I just opened this volume, and we're going to evaluate later on the imaging finding for the fracture. But what is important is this: none of that, the mandibular crowns are interfering with image quality. Another important field of view that we have within Morita is the 4x8. The 4x8 field of view it's the tallest one of all the smaller fields of view out there, and it's super helpful, particularly when we're doing anterior mandibular cases or anytime that the patient has deferred pain. So if I have a patient with pain on number 16, but I don't know if it's number 16 or 46, I would use that. So the idea here is remember to use the 4x8 scans. They're very, very important. I also use this particular field of view for all my trauma cases. Typically, this is what I use if I want to evaluate the anterior deep tissue during trauma. And the beauty of this particular scan is the fact that I can isolate the mandible and the maxilla. So I'm gonna, in a bit, I'm gonna show you how do I adjust the histogram and how do I keep it like that. But what is important for you to know now is that I can isolate a maxilla or a mandible or see one of those arches at a time. I don't know if you know this trick or not, but Morita has what I like to call the zoom box. So if you go under tools here on your i-Dixel, if you go under tools on i-Dixel, this button right here that looks like a cylinder, when you click this button, this yellow box pops up, okay? And when this yellow box pops up, I can actually move this box using my coronal, sagittal, and axial lines. And every time and if I click on the edges, I can make it smaller, I can make it larger, right? I can kind of move it around. And if I double click the edges of that box, again, we're going to see me double click the edge of the box. I can now zoom in to the information that's inside that box. So as you can see right now, I only see the maxilla, and I'm paying attention to the incisive canal area here where I have an incisive canal cyst, right? I can measure that, and now, you know, do any type of annotations that I need for that particular region. And in order to come out of that, all I have to do is double click inside the box. And now I'm out of that box. And to go to the mandible, I can, I'm going to create another box. Just moving my axial image there, and click on the box here under tools. Remember, it's this little cylinder part there. See that? That's what we're going to evaluate. Click, and now I can zoom in. And by the advantage of zooming in versus what I just did, which was to drag the images around, is that allows me now to see not only one plane magnified, but all planes magnified. So the axial, coronal, sagittal views are magnified. That was a lingual canal there. One thing that I always want you to use are the tool annotations, and I'm going to show you later why this is so important. But every time that you have a finding within your cone beam, please add some sort of annotation within your scan, because that later can be so helpful for your doctors that they're receiving the scan to actually see and understand your reports and see and understand what the findings are. Another thing about all Morita units is that they're very friendly for wheelchair and larger patients. So for example, this is a patient that weighs over 380 kilos. As you can see here, he's on a wheelchair, and we can image him with the Morita. As long as you use those tools that I told you about, position 1, position 2, position 3, or horizontal position 5 on the X800, we can definitely scan those patients, no problem. One issue that I see that happens a lot with all units that the patient are standing when you're taking the scan is the issue of height. I am a very tall individual. I am 1.93 meters, so I'm 6'4" here in the US. And it's not easy for assistants to position me because I'm so tall. So one thing that I always recommend for all imaging centers and offices is to acquire images with the patient sitting down. If you acquire images with the patient sitting down, you have two advantages here. Number one, now all the patients are homogeneous. It doesn't matter how tall the patient is. Your assistants are going to be able to see their faces well. You're going to have better patient stabilization because you have the ability to sit the patient down. Particularly elderly patients, this makes a huge difference. And then number 3 is this: by bringing by sitting down the patient, you bring in the center of gravity of the unit down. There's less wobbling. There are better harmonics on the unit. So on average, you'll have better scans by having the patient seated and when the patient is standing. The secret is, what do I need to sit the patient down? You need a chair with wheels and also with back support. That's the ideal chair for you to acquire an image. So why is this important? Because by having a chair with wheels and back support allows you now to have the patient sit more towards the edge of the chair, and I'm being very exaggerated here. But the idea here is if I ever encounter a patient with a hunchback or neck issues where the chin line or the jawline is below the shoulders, I can have the patient sit at the edge of the chair and then just push the patient in. And as I push the patients in and the patients lean back, as I lean back, what's going to happen is my shoulders now are going to drop down, and I'm going to get clearance around the patient's head. Okay, so that's why I have the back support here, so I can really lean back as you're taking the scan. All right, so I would strongly recommend you doing this. And when it comes to the X800, at least in our clinic at the University of Louisville, all the scans that I acquired with this particular unit, the patients were seated. I thought it was much easier to acquire images with the patient seated. So as you can see here, we have a little chair. Patients would sit on that chair, and that would be just much easier for us to stabilize the patient. One thing that I'll tell you is not to do what this lady here is doing. See, this patient here has her foot flat on the ground, her feet flat on the ground. This lady does not. This gentleman here has it. So as much as you can, make sure that their feet are flat on the ground so they have better stabilization and they don't move themselves. Okay. Another trick that I'll show you to anybody here that has an X800 is this. If you can, place a mirror in front of the unit, okay? If you place a mirror in front of that unit, it will help you because the patients are going to able to see the lasers, and you have better patient cooperation when taking the scans. So anybody that has this capability, if your imaging lab or your office where the unit is installed, if you have a wall there, I strongly encourage you to putting a mirror on the wall. It can be just a simple mirror, a cheap one, because what happens is it's this, by having a mirror on the wall, I'm just going to switch decks here really fast. What happens is this, you have the ability now, the patient has the patient now can see the lines, right? The lines in front of them. And if anything happens, you can ask the patient to just, adjust the face themselves. So if you are here and the patient is tilted or crooked, and you have a mirror in front of them, all you have to do is say, hey, can you please line up your face with that line that you see there, with that laser you see there? And then you have perfect patient cooperation. Okay, so that's why it's important that you guys add the mirror on the wall. So you have the best of both worlds. You have the patient facing the operator, but you can also have the patient seeing themselves, and that will help. Okay, now as we position the patient on the unit, now comes a very important piece of information for you, which is to select the appropriate field of view, or FOV, on a patient. So you have within the Morita family 3 options. You have larger fields of view, you have medium fields of view, and you have smaller fields of view. And it's important that you understand why are they there, why do we use larger, medium, and small, and also what are your expectations related to the resolution of each one of those fields of view. So basically, you're going to have good resolution with larger fields of view. You're going to have better resolution with medium fields of view. And you're going to get to best resolution when we get to smaller fields of view. The ideal scenario here is for you to think about what is more important to you. Do you want quantity of information, meaning do I need larger fields of view, or do you want quality of information? Do you want smaller fields of view? They are different, and the expectations about them should be also different. For example, if I want quantity of information, meaning I want to see larger fields of view, it's very hard to see detail. Although this is not a Morita image here on the left, the larger the field of view, the worse detail you will have. The smaller the field of view, the better detail you will have. So what is more important, quality or quantity of information? If you want quantity of information, perhaps you're not going to be able to see root fractures. If you want to see root fractures, you're going to have to go to a smaller field of view and not have quantitative information. Meaning I'm not going to be able to see all the maxilla, all the mandible, all those patients. And the reason for that is because every time that I have a larger field of view, right, there's going to be some computational issues associated with the image. And it starts with voxel size. So the larger the field of view, which will give us good resolution, I'm going to have larger voxels. Typically on the X800, when you're doing a larger fields of view, your voxel size is 0.32 microns, which means that you're at 320 microns of resolution. So 0.32 millimeters, I'm sorry, for resolution. If I go to medium fields of view, and that's now when you do your 8x8s or your rouleau triangle acquisition, you're now dealing with voxel sizes that are smaller, and they're about 1.6 millimeters or 160 microns in size. So remember, voxels are three-dimensional pixels, right? They're cubes. But just so you guys can visualize, you understand this concept. Every time that I'm dealing with this type of voxel, if I were at 0.32 before, and now I'm at 0.16, I don't have double the resolution. I actually have 8 times more resolution, because where I had 1 voxel before, now I have 8. So it really, from a display perspective, you know, if I can have 8 voxels displaying information where before I had 1, it's much better. And the idea here is, this is actually a 10 by 10 from an equitomo, is that I can actually start to get very good image quality, although I still have some scatter from some of the crowns. The overall resolution of the scan, to look for bone, to look for detail of the anatomy and detail of the dentition, is pretty good, okay? But in many ways, what we're looking for here, it's the showstopper, right? Where Morita is known for, the ultra high resolution that we have with the smaller fields of view. And in this particular case, what we are doing here is we are using a very, very small voxel size of 0.08 to achieve the best resolution the unit can display. So the 0.08 voxel size of Morita, it's not by chance. This actually comes from the work of Dr. Yoshinori Arai, who is the father of high resolution Conebeam-CT imaging the way we know it. And what he determined with his studies is that 0.08 is the smallest voxel size that you can go to without, and this is important, without loss of resolution. To be honest with you, the 0.8 or 1.6 or 0.3, those are all arbitrary numbers. Morita determines this, or any other manufacturer determines this from their Conebeam-CT scans. You can actually reconstruct any volume with Morita with smaller voxel sizes. i-Dixel has that capability. You know, the equitomo actually has a module that allows you to reconstruct a volume as 0.20. Right, so you can go to 20 microns with the equitomo. Does that make the image better? No. What it does is actually introduces a lot of noise to the volume and actually tanks it. So Dr. Arai actually said that 0.08 is the smallest you can go without the detriment of the image quality. That's why Morita keeps a 0.08. So if another manufacturer tells you, oh, I have a smaller voxel size, that therefore I have higher resolution, it's nonsense. It doesn't make any sense. Actually, does not increase resolution whatsoever. Actually shoots themselves on the foot. And I'm going to show you this here, why, in a second. So the idea here is this: the smaller resolution, right, the showstopper from Morita, is the one that's going to give us the highest image quality we can possibly get. We can possibly get, and give us the amount of detail that we need from bone trabeculation, PDL spaces, and of course, root anatomy. So from a visual perspective, this is where we are today. We have here good resolution, better resolution, and best resolution. So remember, When you take a larger field of view with your X800, and now you're dealing with a Vox of 0.32 millimeters, which means 320 microns. In the same area, if you were to acquire an image with a smaller field of view, 4x4, you would have 64 voxels displaying the same amount of information. So please understand this. Your ability to display detail is going to be related to those numbers. However, it's important to stress that your final resolution, it's not just the voxel numbers. There is a lot more to resolution than just voxel numbers themselves. I'm just trying to compare this here so you can actually have a visual understanding of the importance of the ability to display detail. So you can have good, better, best from a display perspective. So what is the difference between that? Is the difference between good quality, better quality, best quality, then the ability to display detail. So when do I need this? When I need quantity of information. When do I need this? When I need quality of information. So there are two different things. Now, how about the voxel size, right? We keep talking about voxel size, voxel size, voxel size. Is that important? Not important? That's what determines resolution. So we have this Voxel Wars happening right now. We probably have competitors telling you and Adana saying, hey, you know, my machine is better than theirs because my voxel size is smaller, and so on. So this is actually not true. If anybody tells you that they have a higher resolution than you because their voxel size is smaller, they're flat out lying to you, because final resolution does not only depend on voxels. Just to give you an idea, this is what determines high resolution on a scan. It's all those factors here. So it goes all the way from the sensor quality to the focal point, to the spatial resolution of the volume, to the field of view. How do you aim at the field of view, the amount of noise, artifacts, the number of base images, what was the KV, what was the MA, what is the air gap, which is the distance between the sensor and the tube head. You know, how do you stabilize the patient? How about the sharpness of the scan? How much I can see the edges of the scan? And this is a problem right now because a lot of manufacturers are trying to trick people to actually have beautiful images, and they are using filters to remove sharpness. And by doing so, they are actually removing a lot of really important information for the scan. So the ability to see sharpness is actually really important, in my opinion, when it comes to diagnosis. You know, overall, what is the general projection of the scan? What is the DICOM output quality? What is the dynamic range of the image? Meaning how many shades of gray and black and white can I see? You know, the amount of contrast, of course, those, you know, what type of maintenance do I need? Calibration, and calibration during installation. So those are all things that can control, like, I'm sorry, that can impact your image quality. And therefore, without paying too much attention to voxel size, if any of those parameters are off, your voxel size won't matter. So please don't let anybody tell you that just because they have a smaller voxel size than you, they have better image quality, because it's just not true. And in order just to show a point, you can look at a volume here that was acquired at 76 microns, right? And you can see that the image is just very noisy, extremely, extremely noisy. And when we look at a very similar scan acquired with the Morita with a voxel size of 0.125, the image quality is superb in that perspective. And the difference here is very, very large. And that has to do because it's not only about the voxel size, it's about parameters. So what is it that you need to do when you scan your patients in your practice? Make sure that your KV is always maxed out. Okay, so for everybody that's listening to me right now, make sure that all your acquisitions are done with KV 90 if you have the R100, and KV 100 if you have the XA. This is very important. And then typically, this is what I use for my MA. If I'm dealing with a child, I will do MA5. If I'm dealing with anterior teeth, I'm doing MA6. If I'm doing premolars, I'm doing MA7. If I'm doing molars, I'm doing MA8. And if I'm dealing with an area that has endo or implants, I am doing MA8. Okay? This is very, very important in order to maximize your image quality. So again, child 5, anterior teeth 6, premolar 7, molars 8. Anytime that I have endo or implants on the dentition within my field of view, I'm going to use 8. You're welcome to copy those settings. That's what I use here in the US. And for those that are using the new X800 that has the new tube head with 100 kV, this is just outstanding, because the higher the kV, the less amount of artifacts you get. It gets to this point where you can see the implant here, and you really can appreciate the fact that we can even see the buccocortical plate with minimum artifacts associated with this. Okay, so in this particular situation, which MA would I use? I would use MA8 to really minimize all the artifacts associated with the dental implants. So here's another good example of a 8x8 scan of the maxilla. Therefore, we can zoom into the dental implant. And again, this is a 90 kV with 8 MA, I'm sorry, 100 kV with 8 MA, and therefore very little amount of artifacts, but starts with acquisition parameters. It's important to also stress that there are different types of dental implants out there, different types of scatter. And typically the higher the anatomical number of the metal that you are scanning, the more likely you will get to have artifacts, or what's called beam hardening artifact. And what is the best way to avoid beam hardening artifact is to maximize your acquisition parameters. So make sure that you're taking scans with the longest acquisition time. The 17-second scans are preferred over the 9.4 second scans with the X800. Another thing too is that if you need the maxilla, for example, you can do a separate scan for the maxilla and for the mandible. And I would use the maxilla. I would use the 8x8 scan in high definition with the X800 in order to avoid those artifacts. So if you're going straight to the rouleau triangle, which is the 9x8, the 9x8 acquisition is actually a 9.4 acquisition seconds. You're not going to have the same resolution as the 8x8 field of view. So one more time, if you have an X800 within your practice, avoid use the 9x8 whenever you have to deal with artifacts, and use the 8x8 scan with the HD module at 17 seconds acquisition. That will increase your resolution substantially and decrease the amount of artifacts substantially related to dental implants and crowns. Again, that's when you get those beautiful scans with endo, high KV, high MA, all right? For those who are thinking about upgrading your units, your i100 to the X800, what is the basic difference? The basic difference between those two units is that because the X800 has a much better tube head and projection geometry, it's the upgraded version of it. Situations like this where you have beam hardening, right? And you compare side by side of the same patient, you can see that beam hardening is pretty much all gone. And that is the reason why you should be scanning the patients with high KV, high MA. Difference between the R100 and the X800. And David, I can take questions right now if that helps.
Actually, it was some of it was on parameters. There are some machines on the market as well that have 120 kV. And they're wondering that if that machine has 120 kV, would it be even better?
No,
than what we're seeing here?
It's very simple. No, you wouldn't. So by that logic, 140 would be better, 160 would be better, and so on. So it doesn't quite work like that. Number one, remember, if I go back here to that slide that talks about what is resolution, right? Here, there is a lot to do with you can have a lot of power coming in, but it doesn't necessarily mean that your sensor can actually capture all that information from that extra power. That is one thing. The other component too is also the number of base images. You know, you're going to have units out there that have a gazillion amount of base images, but they are terrible on an image quality perspective. And the interesting thing is this. Give me 1 second here and I'll show you. This is the tube head for Morita. Okay, so you can see here there are a few windows, and that's the collimation for the panoramic. You can see here is just this thin line, right? And what is the difference between Morita with 100 kV and all the others with 120 kV? Is that when we actually select angle module on the Morita, it takes away what's called the copper filter of the unit. So there's a copper filter coming down, up and down. So when you are going, you're changing your acquisition. One of the things that Morita does is on the endo module, it actually removes the copper filter. And what it does, it's actually filters that 120 kV and creates a lot of noise on the volume on the other side. So the fact that Morita can actually remove that copper filter is one of the reasons why we can actually increase the resolution instead of decreasing the resolution. The other component about Morita that is very different than everybody else, and people forget about it, is that Morita is a continuous acquisition, where everybody else is actually flipping, is flicking. You're like flicking acquisition. So it's a pulsated acquisition. And so the quality of the X-ray beam on Morita, it's extremely better. Remember one thing, whenever we are talking about the X-ray beam coming from a tube head, we are talking about what's called a polychromatic beam. There are different energies there. You know, you can reach out to 120 kV, but it doesn't mean that all the photons on that particular tube head, it's coming at 120 kV, particularly when they're pulsated, because you're generating new photons, new explosions in every single time, where Morita is actually continuous. So the projection geometry and the quality of the X-ray beam on Morita will be much, much better. And in part is because of the lack of copper filtration, and also because of the continuing exposure versus pulsating exposure. Does that help?
It does, actually. We have actually experimented with pulsating exposures as well, but our R&D team was simply not satisfied with the quality of the output.
Correct.
So we can
very, very correct. One of the most important features of Morita, of the software, is the zone reconstruction. It's important to stress that the zone reconstruction doesn't work on all volumes. If you have an X800, the maximum field of view that you can acquire the image is an 8x8. So if you have an Aquitomo, then it doesn't matter, works with all volumes. But the X800, only up to 8x8. You have to acquire the volume with 17 seconds in order for the zone reconstruction to work. Okay, so you have to acquire the volume with the HD module for the zone reconstruction to work. So how does that work, the zone reconstruction? So the idea here is, I acquired a mandible, and as you can see, there are many interesting findings with this mandible. This was for dental implant. You already saw that there was some sort of a cylolith here, but I'm going to be more focusing a little bit more on the anterior dentition here. I'm looking at the center incisor. I'm going, there's something weird about that center incisor. So I click here on the reconstruction icon. I can click now on zone reconstruction, this little icon right there, zone reconstruction, and this circle pops up. I can determine the size of the circle, right? I can just put it over the area that I want to reconstruct and determine the diameter of that circle. So here, I don't need to do 5 centimeters. I just need to do 30 millimeters, which is 3 centimeters here. So I select that area, and now I'm going to choose the voxel size that I am going to use. So as I told you before, Morita has the ability to go even below 80, right? So this could go to 20, but the vast majority of you will see 80 here. So we're going to click 80 on that case, 80 microns. Then I typically change my slice thickness and my slice interval to the minimum voxel size as possible, which in this case will be 80, right? 80 microns for 1-1. Just keep it a 1-1. And then all I have to do now is hit the button run. So I selected the area, I selected my new voxel size, I selected now the smallest interval, the smallest thickness, and I hit run. What the computer is going to do, it's use the base images acquired for the large field of view and reconstruct a brand new volume just for that area of interest. So it takes about 3 minutes for this process to work. I'm just speeding up the video here so you can see it's doing its processing. Say yes or no, up to you if you want to save this or not. And now it's going to open the new volume. So the moment that he opens the new volume, you can see now that this is a 3x3 scan. And now it's just like if I had acquired a smaller field of view of the anterior dentition. So I can go in now and start to evaluate, the area that I thought was happening. There was a problem, and I was right. See, you can see now that there was invasive cervical resorption associated with that area. Then I can start doing all my imaging manipulation. I can change my slice thickness, and go from there. And you can clearly see now that, I didn't need to go and take another scan to highlight the fact that this tooth had invasive cervical resorption associated with it. Yeah, so that's how you use zone reconstruction. Okay, there's really no secret here. It's very easy for you to use. It's very helpful anytime that you need detail of an area, right? Particularly after the patient left your office or left your imaging center. And you don't, you avoid having to call the patient back and say, hey, come back, I think I see something, I want to take another scan or whatever. So that is very helpful. Another thing that it's important for me to tell you, it's how to enhance your scans. I've been using this now for years. I've been lecturing this for years. I use this now on pretty much every endo scan I acquire, which is how do I improve image quality, okay, for endo scans. So I would ask everybody that's hearing me in here now to use this technique. So instead of taking a scan where the patient, has the lips or the buccinator muscle collapsing against the gingival tissue, this is what I want you to do. I want you to now, every time that the patient comes in for a scan for endo, place a cotton roll on the buccal aspect of the tooth of interest. Okay, so if you place a cotton roll on the buccal aspect of the tooth of interest, that will push the buccinator muscle away or the lips away from your gingival outline, and will allow you to better see the soft tissue of the patient. So you can use also lip retractors if you want to do larger fields of view. If you're doing smaller fields of view, the cotton rolls are preferred. They will enhance the buccal cortical plate for you, and most importantly, they will give you this information here for the soft tissue outline of the gingiva. So anybody that's doing scans for perio, you can actually start doing perio analysis for your doctor. So basically, you measure the distance between the CEJ and the alveolar crest, the thickness of that soft tissue, the thickness of the cortical bone here, and the thickness of the soft tissue as well. So your periodontists are going to love you for this if you provide this service. One thing that I use a lot, particularly if you're doing medium fields of view or larger fields of view, it's this guy. It's called the Free Access 2 from Morita. It has this little wing here that pinches the buccinator muscle and opens this buccal corridor all the way back to the third molar area, right to the tuberosity area. So the way this works, it's like this. I place this inside the patient's mouth with the metal part, going up towards the patient's eyes. This will not interfere with the image quality whatsoever. So you rest assured there will be no artifacts coming from this. And then you can now go take your scan, and this will allow you now to image the patient all the way back to the tuberosity area, and really helps you better evaluate the soft tissue profile of the patient, not only for maxilla but also for mandible. So that's a very good trick for you there to kind of help you enhance your image quality. And if you ever need to see the palate for whatever reason, right? What you can also do is actually place a tongue depressor around, in the backside, and that tongue depressor here will act as a gate that will prevent the tongue from going up. And now you have not only what's happening from a buccal side, but also from a palatal side. So this is how I would do maxillary scans, for example, for implants, because that gives a lot of extra information for doctors related to the buccal cortical outlines of the dentition. Another important tool related to the software, it's the motion correction tool. So how do I use the motion correction tool of Morita? It's not uncommon from time to time for us to have patients with motion. So as you can see here on this particular scan, there's double cortication. See double cortication of the outline. Here we're looking at the frontal bone, but you can see that double cortication there. That means that this patient moved. You look at the dentition area, everything is fuzzy. That's because of that type of motion. So if I go back here to, the scan itself, I can right click on it, right click on that scan, and I can select display CT movie. Okay, I'm going to do the display CT movie, and then you will see the acquisition movie for the scan. You're going to see that it's just loading here. You will see here in a second the acquisition movie. Here we go. And then you observe the acquisition, and then you have to figure it out. When is the patient move? Perhaps the patient swallowed, the patient moved a little bit. Sometimes it is in the beginning of the scan, sometimes it's in the end of the scan, sometimes in the middle of the scan. So the idea here is to try to figure it out. When did this patient move? And after you do that, what's this? After we do that, what we're going to do now is we're going to go back to the same area that we can do the zoom reconstruction. And instead of doing the zoom reconstruction right now, we're going to click on what's called detail next door to it. And we're going to do now 180 degrees reconstruction. I'm going to select 180 degrees reconstruction. I'm going to select the angle, and I'm going to tell the computer, listen, I want you to scan the patient from this point forward, because the patient moved in the beginning and in the end. So I'm just going to use those base images now to reconstruct the volume, and I'm going to say run. I'm going to do a second reconstruction now, and I'm going to eliminate the base images where the patient had the movement. So it's doing its reconstruction now. Then try here. Here we go. Here comes the next scan. Here we go. So now we have the next scan. We can adjust the histogram the same, and all that motion is gone. Now the images are sharper again. So any volume, okay, that is, see, look at that, beautiful. There's no more double cortication anywhere within the scan. So overall, the sharpness, it's great. So anytime that you guys have motion, okay, motion artifact, it's possible to remove it. Mr. Sliman, I actually wrote a paper with Dr. Bornstein from Hong Kong related to this, which was probably your suggestion. We had this talk a long time ago about this module.
Absolutely.
And we published this, and we can actually send to everybody the paper, right? Talking about this and how to implement this.
Yeah, we can certainly put it together. Some images from that show up on one of the brochures as well. This was a accidental discovery by Dr. Bornstein. He had no idea the machine could do this, and he sent us an image that he thought was unrecoverable and just wanted our opinion on it. And we just asked him to do exactly what you did, and he was actually astonished that that was a thing. So yeah, from that the paper was produced.
Yeah, so it was a collaboration which was between us here in the US and him in Hong Kong, and beautiful paper. So I can send it you guys, and this is a huge advantage for Morita. And you can see here the before and after. You can see how fuzzy the image is and how sharp the image is here, particularly on the frontal bone. Now, there were some questions that were sent to me by some of you asking about Conebeam-CT reconstruction. Okay, the CBCT reconstruction filters that comes with the unit. Basically, I would ask you not to change that. You can go here through reconstruction. You can see there's several defaults. One of the things that I want to make sure is that the unit that you guys are using this particular one here, the G003 age plus age 205. Okay, if you're interested in Hounsfield units, if you want to measure Hounsfield units with your Conebeam-CT scan, that age has to be there. You have to be using a plus age filter. If you don't have the plus age filter, you cannot measure Hounsfield units with i-Dixel. Okay, but if he has that, please use it. So ideally speaking, you don't want to change this much. There are different filters. There are medical filters. We use those more with the Aquitomo. But if you're with their 7X800, which is the R100 and the X800, please just keep yours at a G003 plus H205. Okay, do not change that. The other thing that I was going to tell you is, and this is something that I had a discussion with Mr. Sliman, I want to say about 6-7 months ago. We've been working with this together, is that your capture box, okay, your driver box within i-Dixel, particularly for those who work with larger fields of view, the X800, we can actually change the resolution of your reconstruction. So the native reconstruction right now for the larger field of view of the X800, it's 0.32 millimeters, right? So 320 microns. Right now, we have the capability to change the voxel size from 0.32 to 0.25. This is something that I was discussing this with Mr. Sliman before this meeting. So you would have to contact your engineer, your Morita dealer, and they will log in remotely and perhaps maximize that image quality for you on your scans. Is that correct, Mr. Sliman?
Yeah, essentially. I mean, the default resolution can be changed as a setting of the driver. So in the user manual, you'll see how to get access to the driver settings. And like Dr. Azevedo said, we don't normally recommend changing the resolution, the reconstruction filters, but in that same area, you do have the ability to change the default resolution. Now, of course, there's limits to that. We go down to 0.25 on this larger volume. You can't really go much lower. That goes back to the previous discussion that was made earlier in this presentation. You're looking for, quality over quantity, and your computer eventually just hits its limit. You know, we're not able to reconstruct a 0.08 at a volume size that's 150 millimeters in diameter. You just don't have enough memory for this kind of thing. So there will be limits, and 0.25 is one of those sweet spots. It works. There's enough memory to do it, and you can see the results on screen here.
Yeah, you may see other manufacturers advertising this, saying, oh yeah, we can, we have a volume of 10 by 10, and it's a 0.075 micron. The challenge with that is, what do you do with that data? Because that data will be about 5 to 6 gigabytes for one Conebeam-CT scan, and it becomes almost impossible for you to export and actually load into third-party softwares to actually look, to look at the volume. It becomes super heavy and kind of clunky for you to do that, even if you have very powerful computers to run it. So just like Mr. Sleeman was saying, if you change the computational issue here, you're just making really large files, and they're going to be exponentially larger than your normal ones. Okay. But there is one more thing I want to talk to you about, the software that is important, and this is for those who export DICOM for third-party softwares, for example, or Nobel Guide or things like that, to create surgical guides. And this is something that I discovered with Mr. Sleeman this year as well. So we had some conversations about the same time we were talking about this reconstruction component here. And Mr. Sleeman actually developed a little tool called Morita Config, where, again, you call your dealer and they will be able to use this with you if that's what you're interested in. And what we discover is that every time that you export DICOM from i-Dixel, i-Dixel adds a little bit of median filter to the volume. And this median filter actually removes a little bit of the sharpness of the edges of the scan. And that's why sometimes when you are looking at a scan that was exported from Morita, and you're looking at a third-party software, and then you look at the image on i-Dixel, that image will look different, right? So you look at it on i-Dixel and it looks fine. You look on the third-party software, it looks different. The reason why it looks different is because of this filter here, this median filter. So I would ask everybody that's having problems with the DICOM export from Morita to contact your dealer so they can actually go in there and turn it off. Okay, this is what they're going to do. All they need to do is unclick this box that says use median filter when slicing, and then now every time that you export your DICOM, you will have the exactly same resolution and the exactly same sharpness as the image that you guys see within i-Dixel. Is that okay? So that is a little thing that we discovered not too long time ago, but I feel would be important for your market, perhaps because you guys export a lot of DICOM for third-party software. Is there any question there for me?
I don't think there's any question at the moment. We're just discussing recordings here, but actually I do want to make one additional note based on this. With this particular tool as well, and again, your dealers and our local affiliates can help you out with this. You may find that some software has some compatibility issues with DICOM as well. We tend to export just the basic raw data, but there are occasionally some additional headers that some software expects. So if you do have some issues with importing Morita DICOM images into your software, we do have that ability to simply turn on those headers so that they're recognized properly. So it's not a problem with your DICOM files. It's not a problem with your software. It's just a setting that needs to be changed, and our dealers can certainly help you out with that.
Excellent. Thanks, David.
No trouble.
So now let's dive into some cases here. There is a couple things that I wanted to talk to you about when it comes to Morita, and that has to do here. I'm going to show you a couple things that can speed up your process when reading a case. So if you guys go into your i-Dixel, okay? One thing that I want you to do is go to your settings within i-Dixel, go to display, and make sure that under display, this area right here that says 3D viewer, histogram display mode, just make sure that apply default preset value is selected. Okay, this guy right here. Because this will allow you now to create your own histogram template. What do I mean by that? So let me open a case here. Could be anything. When the last patient was looking at, okay, this guy. So let's take a look at this. This patient, you know, sometimes they're going to open, they're going to be like this. I can hit auto here. They'll have something that looks like this, too bright. 3D rendering is not as good, right? So what I can do here is next time you open a case, you can adjust your histogram. Typically, if you guys want to know a little bit more about how to adjust the histogram and the science behind it, there's a whole video on my website, conebeamguy.com, just explaining what I'm doing right now. And just for the sake of time, I'm just going to do it normally. I can go here now to my color presets and make sure that my 3D rendering is great. Okay, so this is something that I always do. And what I do now, you know, if I'm happy with the image quality, I'm happy with my 3D rendering preset rendering, I go to presets and I can create a brand new preset for me. All I got to do is right click on it and say new and type, you know, whatever I want and hit OK. And now this preset, it's saved here. All right. And then from there, what I do here is I right click on that preset and I say set as default. So from this point on, every single time that I acquire a scan or I open a scan within i-Dixel, the histogram is going to follow the densities that I like, the brightness, the contrast that I like, and the 3D rendering is also going to follow the you know, the kind of a segmentation that I like here. So this can save you a lot of time, because if you're having to adjust histogram over and over again, it's very annoying. Other things too is that if I messed up the histogram here, you know, messed up everything, all I have to do is to right click on the image, go here to contrast color and presets, and I have several colors and presets here, see? So this is the one that I just created, Morita. I'm going to click on it and it go back to exactly to that. If I want to change, for example, this preset here to another preset that I created, I can just right click on it. So those are all things that I created in the past, and I can just keep going here. Right, so to keep going back and forth. So this idea of having to adjust histogram over and over and over again is very clunky. And Morita has this ability for you to save your preset, so you don't have to do this ever again. You know, keep moving things over and over again. Just again, find the densities that you like, save it as a preset, right click later on it, and then here it is. You get everything there that you want. So this can save you a lot of time. Okay, so that is one thing that I will tell you. Another important thing that you can do, and this was a question that I think we got from folks that were watching us. So let me put another scan here. This is actually running out of one volume viewer. Let's just see here. Okay, so if I were to adjust this image quality, I would adjust it very fast here so we can kind of play with it. Let's go to the 3D rendering. So the 3D rendering, okay, there are a couple of things that I want to show it to you that is sort of annoying, okay, to me, and it's very easy for you to fix. So a lot of times you see this blue line or purple line. Basically what this is actually showing you, it's where is the coronal plane. So see if I move the coronal plane more interior, this is where this is where it is. So You see it sideways here, it's going to move side to side or back to back, right? So that's the whole point, is just to show you where is the blue line. So that's why it's purple. So you can turn that off pretty easily here. Just click on the first button here, turn that off. Secondly, now the scan is actually, every time that I rotate my axial image here, you can see that the 3D rendering is also rotating. It's off here for a second. So if you want the 3D rendering to rotate by itself, unclick it, right? So just unlock them. So now I can move this guy here, and it's not a problem. If you want to lock them again, you can now synchronize to the volume or synchronize to the slices. So perfect. But what is annoying about the default setting of this software for me, that's very easy for you to change, is this. Please pay attention to the 3D rendering here. Every time that I rotate the volume, see how the 3D rendering becomes pixelated, and then I release, then now the sharpening comes up. So again, one more time, I'm going to rotate, everything here is pixelated, and then I release, and now the 3D rendering is on focus. So if you guys go on your settings, okay, on your i-Dixel settings, you will see here that the dragging resolution for default on Morita is always closer to low. I want you guys to change that to high, okay? Always change that to high. And the reason for that is because the moment that you change this to high, now I can rotate the volume and see how there is no more pixelation of the 3D rendering. I can move this around with no pixelation. Okay, the other thing too, if you want to increase the resolution of your 3D rendering, is go here where it says resolution and change that to 1024. Okay, so those are the two things that I have on my i-Dixel: resolution 1024, dragging high. So if I go back here, you will see that that's already my default setting there. See, high and high resolution, 1024. So the moment that I do this, what do I do now is I go here to this button and say set as default. I click set as default. This has the current settings has been shared. I say okay. Now, from this point on, every time that I open a scan, every time that I move my 3D rendering, there is no more pixelation whatsoever. So this is how you start to enhance your 3D rendering. Okay, this guy goes here. These guys go all the way back there. Now, there are other things related to the 3D rendering that we can do. So I'm going to go back here to that viewer that we were looking at, and that was this guy. What are some of the things that I can do to enhance my 3D rendering? So the 3D rendering area, it's the color presets right here, okay? So typically, this is what I like to do. I like to come in here, click on my color, and you can kind of clean out the noise of the soft tissue, like going back and forth, or you can leave, see how I'm leaving all the teeth behind just by moving my line here. You can kind of play with this, okay? What I notice from most Morita users is that they use one size fits all for this type of scan. So, for example, I can come in here and play not only from do I add more or do I, if I play with this horizontal in here, I'm adding more noise. Every time I got to the left, I'm adding soft tissue. Every time I'm going to the right, I'm playing hard tissue, okay? And then the horizontal line here makes it transparent. So I can make it very transparent if I want to. So something like this, transparent, okay? I can even see here now with my, the frontal sinus of this patient and so on. You can say, Bruno, I don't understand why you're doing this. Well, the thing about i-Dixel and volume rendering is that you can add different colors and different textures to this. So if I go here right now and I say, give me a new color, okay, I just press the plus button here, say new. So I got a blue color here, and I can choose that color that I want. I can go back, come a little bit forward. Let's move this line, in the capacity to the right. Oops, too much. There you go. So I can start making, for example, my restrictions or uh, my occlusal surface look blue, right? So it's interesting because you start now to control densities that you want to add, and you keep adding and adding and adding, and you can create your own template for this. And then the moment that you like what you did, I'm going to add another color here just for the fun of it. Let's add a, change this color to, let's say, red.
And actually, while you're doing this as well, I'll just make a note that since you are doing this, I can imagine on a notebook computer, the
It's kind of
rendering
a
changes are
little
a
bit
little
hard
rough
for me to
on,
manipulate this, but I just want to show the idea. You're right.
yeah, it's a little rough on your microphone. So the sound cuts out when you're actively manipulating the volume rendering.
Mhm. Yeah, so I just wanted to make sure, because this is one of the questions that I get the most. What can you do with this? You can do a lot with volume rendering, as long as you are, moving in different capacities here. So you can, sorry, again, it's kind of hard for me to control what I'm doing. So now the roots are blue, the crowns are red, bone is transparent. This kind of gives you an idea on what is possible, where you have to go and play with it and kind of figure it out. What is that work for you and for your marketing and what you want to try to say. And when you find what you want, all you have to do is go here to presets, right click it, and then you save this as your preset for 3D rendering. That will be there next time you need to use it. Does that make sense? So that's why this is important. All right, so as we are here, a couple of things that I want to show you is that if we need to zoom in any area of the skin, as you know, you can drag it this way, okay, or drag it that way. That is one component. But the best way that I find for you to zoom into any area within i-Dixel is to go under Tools and select the Hide Your FOV region, which is that box. And if you click on and drag the out of the box component, okay, you can kind of go in now and zoom into the area of interest. You can double click this now, and I can see just that area right there, and and pay attention to whatever was going on where we had this extraction, or pay attention to this supernumerary third molar here. So now I can navigate this very easy and focus. If I want to get out of here, double click, and you're there. So if you want to zoom into the images, that was one of the questions that we had from somebody. That's the best way to do so. Use the zoom box, which is this guy here under Tools. All right. Okay, next question that I had that I'm going to address here was a question related to how do I mark the canal? What are the best ways to mark the mandibular canal within i-Dixel? So I'm going to show you guys the same thing. Okay, we have here, see how it pixelates because I'm using one volume viewer. Maximize, maximize. So now I can move this guy around, not a problem. How do I mark the canal? So for those that are marking the canal, the best way that I found to use the mark the canal tool is to use the sagittal view for it. So how do I go about that? So let's start with the left canal here. I'm going to start moving around my axial, and I'm going to use my now axial plane, okay, axial view here to start finding where the canal is. I typically, what I do is I go right there where you see the canal. Use my axial view to kind of trace it. So now I know that the canal is right here, see, on this line. So I try to place it parallel to that line, and here it is. Super simple. So here's my canal. So I'm going to use my toolbox. See how I can see the canal really well? Here it is. So every time that you're marking the canal, the important thing is for you to always pay close attention to this, to the top part of the canal. I'm not too concerned about the inferior border of it, but I'm very concerned about the superior border of it, because that's what your doctors are going to be paying most attention to. So if we go here to the, all I did now is I click the mark the canal tool. Okay. So when I click the mark the canal tool, as you can see, I have now a circle. Okay, a circle that is going to be where I'm going to mark the canal. The thing about the circle is this: sometimes the circle is the size of the canal. Sometimes the circle is larger or smaller than the canal. So what you can do is, if you hold your right button down and you use the your mouse wheel, you can make that guy larger or smaller. Okay. So it's I'm controlling this. I'm just holding the right button down and controlling the size of the canal, or the diameter of the canal, with my mouse, the mouse wheel. So after I find where I want to place my first dot, the idea here is line up the upper part of the circle with the superior cortical outline of the canal. So I'm going to put my first dot there. So I'm just going to release now my right button. And here is my first dot. This is a point, and this is where I started to mark my canal. So I can go and move a little bit. I typically move just about the same diameter of the canal here, and I add another click. So right click on it, and another one, click, and another one, click, and another one, there, click, and another one, click. If you feel that the canal is moving in direction, I can always scroll to kind of change positions here. So, you know, if this guy here is, I can always move this guy back and go back to, you know, if I feel the canal is getting tighter, I can make it smaller. Go there, no more points, all the way to where the mental foramen is. And now I'm going to move my lines a little bit more buckle with my wheel. Double click it, I'm done. So you guys can see here that I marked the canal really well. So the other thing that I did was I marked the canal with a lot of points. Why is that I marked the canal with a lot of points? Because the more points I add, the easier it is for me now to perhaps edit the position of the canal. Okay, so as I was marking the canal, as you guys saw here, I added tons of points, okay, with the canal. And each one of those points, I can actually click on it and then pull them out or bring them down or bring them up. So each one of those points within the canal, I can add the position of the canal with them. So that's why I add lots and lots of points there. So one interesting thing is this, is that if you need to adjust an area within the canal that you drew, and you don't have a point that you can grab. So for example, if I wanted to adjust this area right here, I can right click the canal and I can say here, insert a control point there. So now I have a control point that I can kind of play with it, okay? And what else? You can make the canal transparent. You can change the color of the canal that you want. If you want to make it red instead of purple, you know, you can do anything you want here. And basically that is the best way that I found to draw the mandibular canal. Some people like to use the coronal. I just prefer to use the sagittal. I think it's much faster, much more predictable to do this. So this is how I do the mandibular canal component. Okay. Then if you wanted to perhaps, you know, plan dental implants for somebody, there are different ways to do that. If you want to plan implants, and I'm going to go back here to my i-Dixel software. Let's go find a case here with an edentulous area. Try this patient. So I have my own presets, right? So I can go here, Rita, or I can go here, some of my other presets that I've used, but just to give an idea on that. Okay. Now, if I want to draw and make implants or make a case here, it's important that you understand this. Every time that you use the curve reconstruction, and that is for you to create a panoramic arch around this patient. If you are actually doing a maxilla and mandibular planning, you're going to have to draw two curved MPRs, one for the maxilla and one for the mandible. So how does that work? On average, what I like to do is I go here to you can click directly on curve MPR, or you can go here to tools and click on the draw MPR. And you start from where the condylar head would be, and you try to follow the center part of the dentition. You can double click that, and that will create our panoramic arch. Okay, so you can see here that I drew a panoramic arch focused on the maxilla, not too much focus on the mandible. And the other thing that I can do now is to change the slice thickness of this cut. On average, this should be an 8. Let's see here, thickness. See, it's an 8. Actually, this is 15, but I can make it a little bit thicker. Let's go 30. And now I will see this a little bit better. And the reason why I don't see the mandible, okay, and that's the reason why a lot of times I draw two arches. It's because here it's enhanced for maxilla. Let me make this a little bit thinner. Go back to 15. And then if I bring this line down here to the mandible, okay, look at that. The maxilla, the shape of the maxilla doesn't match the shape of the mandible. So that's why it's important that you always draw one panoramic reconstruction for maxilla and one panoramic reconstruction for the mandible. If you just want to draw a panoramic reconstruction really fast, I'm going to show you what I like to call the dirty trick, the dirty panoramic reconstruction. Sorry, let's go down here and delete this. I'm going to say I don't want to save this guy. How do I do this very fast? It only takes 3 clicks. So you go 1 TMJ, needle line, other TMJ, double click, and now it gives you kind of this arch that gives you like this dirty little panel, like very fast. See, so I call it the 3-click panel. So I'm going to show you another case here that doesn't have a lot of issues. So if you put here in the middle, you go curved. Look, you go back, forward, back. Here is the pan. Okay, so that's a very kind of it's a simplistic way to do things, but it works. If you, all you want to do is like a little thing, but if you really want to be precise, you're going to have to go one for the mandible, one for the maxilla. So let's do the mandible here. This guy, oops. You. Say here. Let's delete this guy and go 1, 2, 3. See, write it always in the middle. Follow the middle of the dentition. Where head is. And you will see that we'll have the mandible now enhanced and the maxilla not enhanced. So it's important that you do that. Okay. From here, we're going to go in and start, looking at that area where we're going to place the implant. So in this case, we're going to go back to the mandible. We can try to find what the path of insertion of a dental implant is. So one of the things that I would ask you is that if you are planning implants for oral surgeons, periodontists, or helping them plan the implants, have them do a radiographic guide for you. That would be very helpful if you can do that, because that will kind of give you the idea on where they want the implants to be placed and so on. I don't think it falls on your responsibility to know this. It will be more on the responsibility of the clinician sending you the patient for scanning and perhaps giving you a radiographic guide for that. But if that is the case, you want to place an implant in this area, one more time, I can put the, I can do the guide there, right? If you feel that this patient, oh, it's twisted, just turn it. Okay, so now it's correct. And the idea here is, okay, let's go plan an implant here for this right side. So we can go to your implants tools. So here under tools, you got your implant. You should have a robust implant library there. Here you can see I have all those implants on my library. I can go to a very famous implant to go Straumann. You know, I want to go a standard, but this guy, see, this guy is discontinued. So let's go soft tissue level 1, and I can choose what implant I want to use. I want to say I want to use a Lato 10. Am I using this lower jaw, upper jaw? So you can do lower jaw here now, and I can just say create. And the moment that I create that implant, now I can move it around. How do I move this implant around? Is I can just click on it, right? And you can see here that I can move the implant around in any direction I want. So I can place it right where I think it needs to be. And the dental implant now is showing on this particular, on the 3D rendering. A cool thing that the Morita software has for, you know, the position of the dental implant, I'm just going to screw up everything here, is that you can, after you place an implant within i-Dixel, you can go here to this button that says align the volume with the implant. So you click on this button. There we go. Line, now it's upside down, but guy here. So now everything is aligned, and I can go around with my volume 360 degrees here, and you kind of check to see if the implant is there. So that's why you would do this. It just aligns the scan with the implant. So you can rotate and just make sure it's there. The reason why I keep telling you to add the annotations is that if you know what type of implant system the doctor uses, you can actually drop this here, and this will be the implant that will be sent on your report, right? So we plan this with a Straumann 3x3 by 3x3, 3.3, I'm sorry, by 10. So add that there. And you can capture those images, print those images. But if you send them just the viewer, okay, you send them the viewer like this. It's important that every time that you send doctors viewers, you guys add as many annotations as you can. So for example, there is a little, I don't know, idiopathic osteosclerosis here on the other side. Let's do that. Let's just put an arrow here and just say idiopathic osteosclerosis, right? So there is the arrow. So the arrow here is very big, so I can right click on it and say decrease size and decrease size. And one more time, decrease size. So here is that. Here is the same area there. So I'm going to do the same thing. I'm going to add another arrow. This position. And say, right click on it. Decrease size. And decrease size. I can also go in and say what this is. So this is roses, okay? So right there. Why is this important? Because when you send this to your doctor, right? You send this viewer to the doctor, one volume viewer to the doctor, and you add all the annotations here. All your doctor has to do is click on those annotations. So I can come in here and double click that. See, it takes me straight to that finding. I want to see the dental implant, double click that. It takes me straight to that finding. So every time that you guys are reading scans and making measurements and doing annotations, make sure that those annotations are here. And then when you export the diagram, okay, when you export the diagram, you guys are going to click on this button right here that says export images and do current state, okay? Current state. And as you do your current state, you say yes and okay. And, you know, you can put this on anywhere you want, on any folder you want. And next time the doctor opens the one volume viewer on their computer, all they have to do is click on the things that you added there, and we'll take you straight to that position. So it's much faster for the doctor to navigate with the annotations. All right. And with that, my friends, my time is coming up here, David. I have about 10 more minutes with everybody.
I totally understand. I mean, I really, really thank you for for cutting this so close today. So yes, if there are any last minute questions for Dr. Azevedo, this would be a good time to ask. If there are any other questions on operation or maybe just minor technical things, I can also stick around personally for a little bit longer.
Yeah, if you guys are interested, you guys can go here. You go to this website here. This is my personal website, theconebeamguy.com. And you go to courses and you go to mastering i-Dixel. There is another 1-hour webinar here for free with all kinds of tricks about i-Dixel on histogram and things like that. So you guys can watch this at any time. Okay, Conebeam-Guy/mastering i-Dixel. And then you just watch the webinar here.
That's excellent. Thank you very much. At the moment, yeah, it's looking fairly quiet. So I think we can also ask Ahab and Hideshi, who are two of our representatives for the region. They can also gather some of these questions after the fact and pass them along to us. So we'll be very happy to answer any of the additional questions that you may have.
Sure. Yeah. So one last thing here, David, if you don't mind.
Sure, of course.
One of the questions that I had, I forgot to answer this. It's when do I use dual NPR, right? So the dual NPR, it was actually meant for the TMJ area. So anytime that you have larger fields of view, that's when you actually do your dual NPR analysis. So you're going to draw, the lines here for the TMJ, right side and then left side, and that's why you have the TMJ. So this, just move the white line so now it looks like that. This is, move the sagittal line away. So here we go. This is how was meant to be. This was meant to be used for the TMJ region. Okay. So now you can see the cross sections and so on. You can do TMJ analysis with the dual NPR. However, again, I didn't have time to go through a lot of the stuff that I thought I was going to have time to. Let's say, let me get this case here. You can also use the dual NPR on endoscans. So you can go here and say dual NPR and use this guy from here to here, where you can now look at cross sections, right? And then you can look at this guy from here to here. So now you can look at coronal views. Oh, sorry, sagittal views. And the idea here is when you are in this module, you can right-click it and you can change your slice interval. So right now it's 2 millimeters, but let's do 0.5, and you can see now that every time that I move this line, it moves 0.5 millimeters. In this case, you can even start seeing the vertical root fracture right there. So for those who want to see vertical root fractures, I know you're tempted just to look at the axial view, but what I look for is this. Find where the vertical bone loss is, find the large diameter for the lesion, okay? And then line up that large diameter with the lesion here, with your, this area, and then move your, in this case, your sagittal view all the way to that region, and look at that. Suddenly that the fracture becomes alive. And then you can right click, you can change your slice thickness, make it a little bit thinner, and make it a little bit thinner, and even add sharpening to it. And if that is the case and it becomes too thin, becomes too noisy, although I can see the fracture really well there, Morita has one last tool that I wanted to show you, which David created, but it's really, really cool. So Mr. Sliman is the father of this thing here. So you can go to I, and you can change now the filter type from mean to medium and remove all this noise from the scan. So you can go apply changes, yes. And the software is doing now a reconstruction and applying a medium filter to it. And every time that you have a noisier scan, you can do this trick, and you will pretty much clean every single dot that you saw there from noise and improve your image quality. This is something that Morita has. I haven't seen it in many other softwares, but it works beautifully with Morita.
And I'd actually like to share with you as well, since we've got a moment or two while it's doing its thing. We recently released our autumn release of the software, and for the X800 in particular, it comes along with a couple of new filters. And in general, as Dr. Azevedo said, we don't usually modify the reconstruction filters, but we added a couple here that may be of interest to specialists. And these ones are geared towards the reduction in noise. So it sacrifices a little bit on the MTF or your spatial resolution, but what it does is tends to blend the noise a little bit better. There's a couple of different levels that you can apply. So for Dr. Azevedo in particular, may be of interest to have a look at.
So see, this is now the same image we're looking at, exactly the same image. But look at the fracture right there. Okay, and you can see here, we are thickness 0, and we are using sharpening. And now the fracture is very well seen there on the sagittal view. See that? Just because I removed the noise. So it's a really, really important kind of cool kind of a finding. And I'm going to show you now the difference between the original one and this one, so you guys can actually appreciate it. So this is the original scan, and this is what we did. We went here to thickness 0, and we apply sharpening. So this is where it was. Okay, this is where it was, and this is with the medium reconstruction. Night and day. So yeah, I'm excited to see that, David. I haven't seen those new presets yet.
Yeah, I'll send you a note about that later. It's a very, very new release, so it's a good chance to have a look at this. But yeah, this would be the point where there'd be some applause and stuff like that. It's very, very nice.
Yeah. So at this time, man, I think I got to get going here because I got to check out of this hotel. But everybody that's in the Middle East, I wanted to say thank you for, spending your evening here with us. I appreciate it a lot. I hope you guys learned something new today, and always a pleasure to see you all. And I hope you guys can stay safe. Your loved ones can stay safe from those pandemic times that we're living in the world. And God bless you all. And I'll see you guys soon. Thank you.